So we've chosen a market-based approach. We've privatized much of healthcare, and yet our market is set up for failure because we lack all of the fundamental sort of economic drivers of a healthy and functioning market.
Hello. Welcome to the Term Sheet Podcast. I'm Allie Garfinkel, senior writer here at Fortune. And every week on Term Sheet, we go over the latest deals, news, and insights in venture capital, private equity, and startups. Here is where you can listen to some of the most exciting figures in the private markets. Now, if you'll notice, we're not in my usual gaming chair today. I'm actually visiting my parents. So what you're seeing behind me is my childhood bookshelf. Let's see what we got over here. We've got, for anybody who's into it, we have some Charles Dickens. We have Batman the Dark Knight Returns. Oh, and then we have, my dad's a big Winston Churchill fan. I could talk about books all day, but we are actually here to talk about the news of the week. Now, this week, I think is a really great week to talk about consumer, because unless you have been living under a rock, you have heard that Kimberly-Clark, for more than $40 billion in cash and stock, is buying Kenvue, which among other things is the maker of Tylenol. Now, there's a lot going on here. First of all, Kimberly-Clark stock did actually drop in the aftermath of this news. One has to imagine that this is in part tied to how the Trump administration is questioning the safety of Tylenol, particularly for pregnant women. It's important to say the American College of Obstetricians and Gynecologists say that Tylenol is safe to take during pregnancy in consultation with a doctor. Despite what medical experts have said about the safety of Tylenol in pregnant women, this has put Kenvue on the defensive. And it's easy to imagine that Kimberly-Clark might have seen the opportunity for a $40 billion bargain deal. Speaking of Tylenol, this week we're talking to Dr. Toyin Ajayi, CEO and co-founder of Cityblock Health. Now, Cityblock Health is a primary care provider that focuses on populations served by Medicare and Medicaid. Toyin and I talked about her journey from doctor to entrepreneur, AI, and the future of healthcare in the most vulnerable populations in this country. This is our last interview from Brainstorm Tech. Here's Toyin.
Toyin, welcome to the Term Sheet Podcast.
Thank you. I'm so happy to be here.
And welcome to Brainstorm Tech in Park City.
This is great.
I am really excited you're here because we're going to talk about some really intense stuff.
Mm-hmm.
I would love to start big picture.
Mm-hmm.
What is wrong with healthcare right now?
Ooh.
Yeah, I know, really broad.
Like all of it. Okay.
Yeah, I would say like everything.
Okay, so it's not working fundamentally for anyone in the system. So I mean for patients, I mean for payers, I mean for doctors and nurses and other healthcare providers. Everyone is unhappy. And for the privilege of this global dissatisfaction, we also spend like way too much money. So I'll start with the sort of the economics. And, you know, if you think about sort of the value equation, right? Like what do you get for how much you spend? We're failing on every aspect of that. First of all, the United States is pretty unique amongst developed countries in that we spend north of 20% of GDP on healthcare. It is massive, and has been growing. I remember 10 years ago, we sort of thought like, we continue to say, this is an unsustainable rate of growth. We cannot tolerate it anymore. We just continue to grow more. So we're spending a ton of money.
So people have been saying this for decades.
Forever. Like it is unsustainable to spend this much money, especially when we also have some of the worst health outcomes for developed countries.
How bad are we talking here?
So we're talking about life expectancy that is below OECD countries. We're talking about disparities in health outcomes. So the people who have the best health outcomes versus the people who have the worst, the gap between them is large. And as you know, when you have some folks who are doing really well and some folks who are doing not well at all, that creates a whole bunch of other social problems as well. We pay more for drugs than other countries. And out-of-pocket costs, so at the household level, healthcare is the number one reason for personal bankruptcy in this country. American families spend more money on healthcare than families on average in developed countries. And again, we have the worst outcomes.
How did we get here?
Okay, so here's the problem. So we've taken an approach which in principle sounds great. We've said, look, America, what we do really well is we do innovation and we do capitalism. We have market forces that drive people to build the biggest, best ideas and bring them to market. And we let the market determine how much things cost. We let supply and demand curves sort of drive utilization. And we sort of sit back and let the market operate. Now, as you know, markets only work if a few things are true. You've got to have information on both sides. So if I'm buying something, I know what I'm getting and I can value it. Do I like this white t-shirt? Is it going to fit me right? Is it going to keep me warm and dry? Yes, then I'll pay you $20 for it. You need information. You need regulation. You need like systems and policies set from above that prevent bad actors, right? And you need some ability to manage competition effectively so that people can actually shop for choices. We have none of those things operating in healthcare today. So we've chosen a market-based approach. We've privatized much of healthcare, and yet our market is set up for failure because we lack all of the fundamental sort of economic drivers of a healthy and functioning market. What does that look like for you and me? So for people who have insurance through their employer, so folks who are fortunate enough to have a job that pays them a good living wage and also provides benefits that include healthcare, how much visibility do you have in the cost of your care?
I will say, as somebody who has one of those jobs, actually not that much.
Right.
I will get bills that I am genuinely surprised by.
Right.
And luckily, nothing that bad has happened yet, but I could foresee getting a bill that I couldn't afford.
Totally. And if I asked you to shop for healthcare, to decide which doctor to go to in terms of what would deliver better value to you, how would you even figure that out?
When you don't know how much.
Yeah, but you don't know how much anything costs.
Yeah, it's it's the sort of thing that it is one of the only markets where the absolute lack of price transparency does not change the fact that you actually need to engage with that market.
Correct. So you have no choice
Yeah.
but to utilize it. You have no way to discern what is high quality. So cost is only one value, one input into the value equation. What's a good doctor?
What is a good doctor?
Excellent question.
Yeah, what actually is a good doctor?
Well,
You are a doctor.
So I am a doctor.
Yeah.
I would say a good doctor is somebody who has the time, the training, and the right incentives to spend time with you as a patient, to understand what you need, and to recommend actions that they can support you to take that will help you live a healthier life.
Because so one of the things I find very interesting about doctors is it has to be such a very specific psychological experience of the world. You see people in really vulnerable positions. You know things about them that sometimes their friends and family don't know.
Correct.
In a lot of cases. I think there's a reason a lot of doctors have been artists.
Yeah.
Over the years.
Yeah.
It has to be psychologically difficult.
It is, and it's also really beautiful, right?
Yeah.
Like you get to be with people in the sort of fullness and richness of their human experience. And if you do it well, you have the opportunity to make what would be a very scary and an awful experience like less bad by being present, by accompanying a person, by being accessible, and by actually listening to them. The problem, of course, is that many doctors don't have the necessary preconditions to show up as a good doctor. And it's not because they're bad people. In fact, they're often the kindest, most mission-driven, most compassionate people. But when they're forced into a system where they don't have enough time, they don't have enough context, and their alignment around incentives is totally misaligned with yours, right? So give you a typical example. If you go to see a doctor today, they operate within what we call a fee-for-service environment, which means they get paid for the encounter. So if they see you and you have a complaint, they need to see as many people as they possibly can that day in order to make the money work, keep it going.
Yeah.
And say, for example, you come in with a condition that they have a 50% probability they know what's going on, but they're going to write a prescription anyway. They write a prescription for you. You may not have enough time to describe or really understand what the risks and trade-offs are, so you don't feel quite fully informed, and you don't take the medicine. You don't even pick it up. Or you get to the pharmacy and the copay is too high. It's more than you expected. Your doctor still got paid for that encounter. It actually doesn't matter to them whether you picked up the prescription or not from a financial perspective. If you go from their office straight to the emergency room because you were unsatisfied, it actually doesn't matter. They still got paid. Now, it's not the doctor's fault, but if what we want is someone who is incentivized to actually help you get healthier and feel better, then we've actually created the wrong economic structure for that, right? And you think about health systems as a whole. So these are the large organizations that own hospitals and radiology suites and surgical suites and also primary care doctors. They make the most money when someone gets really sick and is in the hospital, right? They get the most money when they do a procedure. It
is a long encounter.
It's a long encounter and it's complex. They will make less money from taking care of somebody with pre-diabetes and helping them with nutrition and coaching and diet and exercise and doing all the really hard incremental work over time to get them into a better position than they would if they just waited until the person comes in needing an amputation for a gangrenous foot. Now, of course, doctors don't want you to get sicker. Yeah. That's not why we did this. Yeah. But the system and the market and the incentives we've created actually incentivize all of that reactive, high-cost care way more than incentivizes all the upstream care. Have you ever wondered what would happen if you missed a doctor's appointment? You scheduled it and for some reason you forgot or what have you. Like,
what does happen?
Nothing most of the time. Because your doctor doesn't have the incentives or the resources or the time
to chase you down.
They're focused on the person who came to see them. But actually in the world, especially the folks that I care for people on Medicaid and people who are on Medicare and Medicaid. These are folks who represent people with the highest level of chronic conditions, with highest needs in the healthcare system, primary care needs, mental health care needs, high utilization of the hospital. It's often the person who didn't make it in to see you who needs you the most. That's the person who might be sleeping on a park bench last night, who may have had their cell phone stolen, who may be in the hospital because they had a mental health crisis, who may be so overwhelmed with the day-to-day challenges of just keeping their household running that they weren't able to get there. That's the person who needs me to go to their house, knock on their door, call them. But we actually haven't incentivized most of the healthcare system to do that. So why is it broken? It's broken because we kind of fooled ourselves into thinking we've got a market-based economy for healthcare. We've privatized a whole bunch of things. We've underregulated the core components of our healthcare system. We've overregulated some parts that have created opportunities for people to make money without necessarily delivering value. We've made it so complex and so opaque that patients cannot actually act as real consumers. They can't shop for value.
They don't have the agency that a consumer has.
It's broken, right? And as a result, doctors aren't happy because we're spending all our time seeing patients one after the other and really knowing deep down that we're not actually helping people. And so that's, the burnout, all of that was happening way before the pandemic, but is exacerbated by the feeling that people are churning really hard, but we're not seeing the outcomes that we want to see. We want to see people healthier, and the systems don't set us up to do that. Patients are unhappy. Trust in healthcare is at an all-time low. 40% of people say they trust their healthcare provider.
Wow. I mean, actually, that
declined consistently over the last 3 decades.
If I'm honest, that feels a little high to me even.
It's possible that it
anecdotally, how did these experiences as a doctor inform your founding of Cityblock?
I mean, it's foundational. Like I didn't start my career thinking I'm going to be a venture-backed CEO.
Yeah, no, it doesn't seem like it doesn't seem like that was the plan.
That was definitely not on the vision board. Okay.
So what happened? What's the story?
Well, I mean, I like so many of my peers and colleagues, like I graduated from medical school. I finished my residency. I did my residency at a safety net hospital, serving mostly Medicaid patients, people with tons of complexity, and like fell in love with how privileged and special it feels to sit by someone's bedside when they're going through a really hard time and being able to help them navigate this complicated healthcare system. And then very quickly realized that actually I wasn't really able to help in the way that I wanted to for all these reasons.
How did you realize that?
I just saw the same patients come in over and over and over again, right? So I was working in the hospital. I was taking care of people with complex needs. So you have a heart attack, you had a stroke, you had cellulitis, so an infection in your leg, your diabetes is out of control, your mental health was out of control. And I was taking care of people at the worst moment. They're in the hospital.
Seeing people at some of the worst moments.
Things have gotten really bad. And we would patch them up, essentially. We'd get their kidneys working as well as we could again. We would take care of that infection as best we could. We'd get them started on treatment for their addiction. We would sort out all of their problems, and we'd then send them back to the world in maybe a slightly better state than they came in, but certainly nowhere near as good as they could be. And then, sure enough, 6 weeks, 6 months, they'd be right back in. And I take this very seriously. I'm like, well, okay, so what gives? And I started trying to experiment and learn from my patients. Why are you back here? Well, okay, if you send somebody who's struggling with diabetes back to a house that doesn't have food. They can't afford their food. They can't afford transportation to all the follow-up appointments you scheduled, or they're too busy taking care of all their kids, or they didn't actually understand any of the instructions because they're so complicated. They're on 14 medicines. They don't speak English as their first language. Like, how in the world would I expect a different outcome? And I started just trying to figure out who was going to come back in and why. And one of the things I learned was that if I asked people 3 questions and based on the answers to these 3 questions, I could sort of like internally predict whether they were going to do okay. And the questions were, first of all, do you have a person in the healthcare system that you know and trust? And the way I would describe it is, if you were in your regular clothes on a Tuesday afternoon and you bumped into them outside Costco, would they recognize you, and would you recognize them? So it could be the doctor. Yeah. Could be the nurse, could be the medical assistant who weighs you and takes your vital signs, could be the security guard at the front desk of your clinic.
How
Is
often
there
do
a
people
single
say
human?
Yes to that?
Very rarely.
I was going to say, I don't know
Far
if I
too
can say
rarely.
yes to that necessarily. Right?
Would your doctor know you?
Yeah.
And like, maybe it's okay for people who are, I'm sort of making assumptions, but who are generally healthy.
Yeah.
You know, I see my doctor a couple times a year.
Yeah.
Not
in my
a ton
doctor's case, my doctor would probably know because I ask a lot of questions in a journalistic way.
Right.
But it's the sort of thing that would be the only reason. And even then it's maybe, and I'm luckily very healthy right now. Right.
And so I'm talking about people with 3, 4, 5 chronic conditions.
Yeah.
I'm talking about people with 14 medicines, people who go to the hospital 3, 4 times a year and stay for 4 or 5 days. Like, you got to have at least one person who knows you, right?
Yeah.
Who you could just like ask a question when you're confused. The second question I ask is, do you have a human in your life who's a personal friend or family member who you trust and you could call 24/7 and they know you? Like any human.
How often did people say yes to that?
More frequently, but not frequently enough. Do you have a human? Any human? And we know loneliness is an epidemic now. We know social isolation is an epidemic now. But so many people would say to me, I have no human. And the third question I would ask is, if I gave you a set of written instructions, could you interpret and understand them? Most of the time we give people instructions in English. Very rarely are they written to a 5th grade level. Probably should be a 3rd grade level. There's all these acronyms we put in medicine all the time. For what? We don't know. We're so used to them. So you came in, you get a discharge summary that says you were admitted with a DVT. It means that you need to take this medication. You need to inject yourself in the gluteal region. What does that even mean? What does that mean?
Yeah.
They don't know.
And even if you think you know, you're probably slightly afraid you're going to get it wrong.
Correct.
So maybe there's a certain paralysis too that sort of sets in.
Correct. And so these are structural problems. Then there's the problems of poverty and proximity to poverty. So Medicaid covers people who are in and around the federal poverty level. Different states have different thresholds for that. But these are people who, generally speaking, have too few resources to operate in the world with a sense of abundance around them. They're pinching their pennies. They're not paying all their bills on time because they're trying to balance their resources. They're struggling to make their daily needs met. And when we take care of new members, a new population of patients, we survey them. We ask them, what are your big needs? More than half of them have an acute social need. I'm worried I'm going to lose my housing. I'm not sure I have enough food to eat for me and my family. I don't have transportation to go to the oncology appointment I know I need to go to. And so we're sending people back out into the world with all of these problems without the safety net of relationships that they need, and with a lack of sort of trusting emissaries back into the healthcare system. And it became really clear to me that I could spend the rest of my career seeing patients every single day, in the hospital, in the clinic, patching them up and sending them right back out, and we wouldn't change the outcomes for them. And that actually the problem was that we have a system that isn't set up to incentivize and to orient healthcare in the places that are actually going to drive most leverage, and that the impact is going to be catastrophic for people. I saw so many people die as a doctor in the most incredible, innovative, and developed country on the planet.
Like, it sounds like it wasn't necessary that it went like that.
No. And for me, it's
What's
just
that
like on a human level, so doctors, as you probably read, and people have talked a lot about this, have been experiencing very high rates of burnout and dropping out of the healthcare system. And again, this came before the pandemic. The pandemic was a singular, awful experience. I was practicing then. I was seeing patients as a volunteer in our safety net hospital where I live in Brooklyn. I was, seeing our Cityblock patients in their homes and in our neighborhoods. It was horrible. But even before that, doctors were feeling burned out and unhappy. And the psychologist described this as a moral injury. It's not because being a doctor is more strenuous than it was 20 years ago or 30 years ago. I mean, old school docs, they were on call 24/7. They were doing home visits. They were they were grinding it out and they stuck it out. The reason that it's different now is because when you're working this hard and you feel like it's futile, when you feel like you're actually, there's a misalignment between your values.
Why do I keep showing up every day?
Why do I keep showing up every day? Right. And so for me, it felt very much like that. It felt like, okay, this is not, I mean, I'm an entrepreneur, I guess, in my bones. I wouldn't have had the language to say this before, but I think people like us are like, we're driven by impact. Like the thing that gets us up every day is like, can I make an impact? And if I'm working on something that I think is not impactful, I lose all drive and motivation. I mean, I think that's sort of true for many humans, but particularly true for people who like start a thing because they want to have an impact. It's not about fame or prestige. Like I certainly never thought about any of that. It's about like, I want to feel like my efforts are making the world better. That's why I went into medicine. And so I started casting about, honestly, for different ways to make an impact. And the first thing that occurred to me as a deeply pragmatic person, like optimistic and hopeful, but deeply pragmatic, is like, you got to follow the dollars. Yeah. Like I've got to understand how we pay for things and why we pay for things, because that is what drives the outcome in a system like this. And that's pretty novel for doctors, actually. We don't often, and this may have changed, but I doubt it, honestly. Yeah. Well, the Academy of Medicine doesn't change that fast.
It's also sort of like nobody becomes a doctor because they particularly want to follow the money. That's why someone becomes an investor or why someone becomes a financial journalist.
But it's naive and misguided to think that you can sort of operate in a vacuum outside of understanding how these things get paid for, right? And so doctors don't get taught this stuff. Yeah. And it translates actually to a place where I think it's actually quite counterproductive. There's something sort of the Academy of Medicine teaches us that we should treat every single person like the same. Like we treat every person the same. We treat people equally. And that's actually just wrong. Because if you come to see me and you're an 80-year-old person with diabetes and hypertension and heart failure, but you live upstairs from your daughter who cooks all your meals for you, and you're married, and you actually know the name of your doctor because you've been seeing them for the last 30 years, and you used to be a math professor, and so you're spending all the time kind of on ChatGPT figuring out and trying to understand your healthcare needs. You are a different human being fundamentally, and you need different things from me as your doctor than the exact same 80-year-old person with all the same diagnoses who lives alone on a fifth floor walk-up in the Bronx and speaks Spanish as their first language and does not understand and has no connections into the healthcare system and doesn't have enough food to eat, by the way. When you're spending time with the 80-year-old who's isolated, you may need more time. Yeah. You may actually need to be paid to go do a home visit once every quarter to just make sure things are going okay.
To just check in.
Right. You may need a translator on your team. You may need a community health worker. You may need to think about how to help make sure she actually gets her meds and not just write the prescription, knowing that the daughter is going to go pick them up. And we don't pay for that today. We don't incentivize the doctor today. We don't say, hey, you did an excellent job taking care of this person as opposed to that person because you went the extra mile. Yeah. And we're going to pay you for it.
Medicaid is under fire, right? How are Medicaid cuts affecting the populations you work with? How are they affecting Cityblock?
Well, it's early still. So they're all due to come into effect in 2027. And I think there's a lot we're going to learn, and there's a lot we have to do to make sure that the impacts are not detrimental on people who really, really rely on Medicaid. So just to sort of set the table a little bit, on the 4th of July, Congress passed the One Big Beautiful Bill Act, which includes meaningful cuts to Medicaid, specifically in an attempt to acknowledge, we all acknowledge that we have unsustainable spend here, right? The taxpayer is spending a lot of money.
You're sitting here saying, no, we actually are spending too much
money.
We are
spending too much money.
I agree.
I'm in. I'm all in. And I fully agree with the problem. And the solution that we today have sort of aligned upon focuses on essentially reducing the number of people on Medicaid by making it a bit more challenging for able-bodied people who work to access Medicaid benefits. And so they're going to need to actually show that they are working, that they're meeting requirements. There's an administrative burden here. There's also copays that are going to come into effect in Medicaid a little bit later on. There's going to be a whole bunch of other impacts in terms of the ways that states can pay for healthcare through the Medicaid budget, specifically supporting some of the providers that find it really hard to keep their doors open because they're so reliant on Medicaid and subsidies. And so it will be it's a sweeping bill. The Congressional Budget Office estimates that about 10 million people or so are going to lose their Medicaid coverage as a result across the country. That's after we've reduced the Medicaid rolls since the pandemic. We had a lot of people who were on Medicaid during the pandemic. We did not push people off because it was such a dire time. And then we eliminated a bunch of folks off of the rolls. So it's going to be a pretty significant shift for folks. It hasn't happened yet, but I can see already there's anticipatory shifts happening in the ecosystem.
Like
folks
what?
are really nervous about this. Congress was pushed to add in a $50 billion budget to support rural hospitals in particular. Rural hospitals are already very much, rural providers, not just hospitals, are very much under threat because they rely a lot on Medicaid funding. It's harder and harder to operate. We're operating on thin margins. And so some of those resources are going to go out.
And you're remote.
You're super remote.
Which magnifies problems.
And it may be, if I'm honest, I think it is a place where the market forces just don't prevail, right? Like there are some social goods you need. You need a place to deliver babies in rural parts of the country. And maybe it's only 5, maybe it's 50 babies a month, but
you still need a place to do it.
The lights have to be on, the building's got to be on, you got to have somebody on call to come in there, right? And that's hard to sustain if you're dependent on a relatively low margin payer source that's under threat. And so there's some places where I think we've acknowledged that we need to start to shore them up. But there are a number of safety net providers across the country who are already anticipating that they're going to struggle to keep their doors open. And they're starting to make anticipatory reductions in terms of their footprint, in terms of their staffing and headcount. That's going to have real impacts in the labor market. Healthcare is the largest employer in our economy in many states in the country. It has shifted from manufacturing to healthcare. And so the ripple effects are really meaningful here, right? And I'm not sure we've fully grappled with those yet either. But a lot of the opportunity, I think, lies in the moment that we're in, where we have two things happening. One is an acknowledgement across the board that healthcare isn't working for anybody. Patients are mad. Doctors are unhappy and burned out, and providers in general. Payers are saying, including specifically the federal government, the largest payer of healthcare in the country, are saying it's too expensive. We can't do this anymore. And so everybody's on notice, which is great. I'm like, finally, we're talking about this. This is so broken. Let's talk about it. This is great. It's a political issue that it's not been before, and this is excellent. We're talking about it.
So actually what you're sort of saying is, yes, there's a lot that needs to be shored up here. Yes, there are going to be serious problems. A lot of people could get really hurt here. But also we're talking about it.
We're talking about it.
Okay.
We're talking about it. We're putting the problem on the table.
Yeah.
Second thing that's happening that I think is potentially game-changing is we're in the middle of this massive technology revolution with AI. And so we have the opportunity, should we choose to take it, to leverage technology to be a deflationary force in terms of cost in our system.
Do you think it actually can be?
And expand access. I think it absolutely can be.
Okay.
I don't think it's a given that it will be, right?
What is really quickly, whatever. I mean, the story of technology since forever.
Yeah.
But what actually will it take? Like, as we start to wrap up here, some solutions, like what role can technology play in improving some of these outcomes?
Oh my goodness. So if you think about what we're struggling with, we've treated healthcare as a scarce resource for the longest time, right? You call your doctor, you wait on hold for like who knows how long. If you're a Medicaid patient, like you don't have some really nice concierge practice, like you're on hold a long time. On average, people on Medicaid are waiting an hour or so in the waiting room just to see their doctor. If you're booking clinic visits, I mean, you could wait 6 weeks to get a mental health appointment. I once rode in an elevator with a patient in a hospital, a safety net hospital, and this woman was sobbing. And I was like, are you okay? You know, like what happened? And she had booked to see her psychiatrist. She'd waited 6 weeks for the appointment. She had missed the call to reconfirm her appointment. She had taken 2 buses, taken a day off work, found somebody to watch her toddler, made it all the way to the clinic, got there, and they told her they'd given away her appointment and she'd have to wait another 6 weeks. So this is how we dole out tiny little doses of healthcare today.
It's absolutely heartbreaking.
Because we operate in scarcity.
Yeah.
If you think about the potential for AI to allow us to move from scarcity to like just sufficient, and then to maybe abundant resources, like this person could maybe not have to wait on hold to get an appointment, maybe not have to wait to see her clinician because we're managing throughput, we're managing access, we're ensuring that our doctors and our nurses and our nurse practitioners in the healthcare system have all the tools they need to be efficient, but also to be maximally productive. We're extending their reach because they can do follow-up calls. We can get your labs reviewed.
Yeah.
Like, there's so much we can do with technology to move from the scarcity mindset to an abundance mindset that will allow us to serve people at a lower cost, right? That is possible. What is probable, knowing our history and our trajectory, is that there are a lot easier ways to make money in healthcare than to figure out how to make it work for low-income people. That's just a fact. You know, when we started our business serving Medicaid patients, we were essentially an N of one. Investors and stakeholders were like, this seems really hard. Like, why don't you go do that over there? That's
like looking at you being like, what are you talking about?
Totally. It's hard.
Yeah.
This is about like, my business only works if we can find humans, build trust with those humans, educate those humans, and walk with them as they make different choices about healthcare. That is really freaking difficult. But look, like, we've figured out behavior change and a whole host of other things. Like 20 years ago, we didn't know that we would be like shopping for groceries, paying our bills on our tiny little rectangles. We didn't know that on average, kids would be spending 4 hours a day on Instagram. We have taught society to behave differently with technology, profoundly, for better and for worse.
So we could actually do it in healthcare.
We could do it should we choose to do it. The problem in healthcare is that there are so many easier ways to make money. And those easier ways to make money tend to be inflationary, right? So let's help hospitals bill and code more money and get paid more for doing the same stuff that didn't work yesterday, isn't going to work tomorrow, right? Let's help health insurers like manage their bottom line by like getting into antagonistic relationships with those same doctors and nurses. And let's just like sell tech to do that and then just race to the bottom. I don't know where we're going, right? Like that's
whatever direction is moving.
Whatever direction is more money spent and the same bad outcomes.
Well, and it's I think the sort of thing here is healthcare is economics, but it can't just be economics either, too.
No, it requires leadership and focus and strategy and policy. And then let innovation run wild, because I do believe that we have the best ideas, the most talented people to go solve these really hard problems, but you have to constrain it. And if we're going to deploy it in a market, we have to make sure the market works, that the conditions exist for us to actually deliver the outcomes that we want to.
Toyin, thank you so much.
Thank you.
You know, lately I've been trying to do a lot more reporting, have a lot more conversations around the depth and nuance of the problems in American healthcare. Recently, I was talking to a healthcare economist, and I point blank just asked him, how do hospitals make money? And he actually laughed at me, not because it was a stupid question, but because it's actually such a hard question to answer. This is the time to be talking to entrepreneurs who are trying to solve problems in a space that has so many of them that it literally shut down the United States government. That's it for this week. I'll see you soon. Term Sheet is a Fortune Magazine podcast. Our producer-editor is Allison Rogers. Our executive producer is Lydia Randall. Our production manager is Sam Freund. Fortune's head of video is Adam Bannicky.